Hi all, welcome back to Emergency Medicine lecture series. One of the important subdivisions of emergency medicine is the toxicology. Toxicology is nothing but study of toxins and management of victims of poisoning. Any emergency physician should be able to deal with any type of poisoning, especially so with the local poisons. To do that, you should be knowing general management of a poison patient. General management of poison patient includes the identification of a poison patient, identification of the poison based on the symptoms and signs, administering antidotes, resuscitation of the patient when a poisoning has occurred, and the general management. I'm Dr S Prakash Babu, Associate Professor of Department of Emergency Medicine, KIMS and RC, Changalpattu. You all know that poisoning is a worldwide problem that consumes substantial healthcare resources and also causes many premature deaths. Exposures commonly occur by ingestion when the patient intends to have a suicidal poisoning. Other routes include accidental, mostly inhalation, insufflation, cutaneous exposure, or absorption through the mucous membranes, and less commonly, injection drug abuse. So these are the routes of exposure: inhalation, wherein the substance is a volatile substance or a gaseous substance which can be poisonous, is inhaled into the lungs, and from the alveolar mucous membranes it is absorbed into the bloodstream and can cause systemic manifestations. Locally, the substance can irritate the airways and the alveoli and can lead to hypoxic injuries. Most common route of suicidal poisoning is by ingesting a substance. Patients ingest substance to cause self-harm. Injection drug abusers will choose injection, and in overdoses they can lead to poisoning. And the final one is the cutaneous absorption. Steps in general management of poisoning: first and foremost, you need to identify a poisoned victim. Your management starts with resuscitation, a risk assessment, decontamination, enhanced elimination, and you need to concentrate something on prevention of further poisoning. Identification of a poisoned victim is done based on the history, physical examination, the symptoms and signs that are fitting into a toxidrome, and some diagnostic testing. Coming to the main historical points that you need to collect in a poisoned victim, most of the time the patient will be able to give a history regarding what substance they have consumed, how much they have consumed, what time they have consumed, and what happened after the consumption. But sometimes patient might be comatose at the time of presentation. They might not be able to provide a clear history. You might need to depend on the friends or caretakers, parents, etc. to get a history about exposure to a poison. The patient can provide history, other bystanders can provide a history. You need to collect the details including the compound, time of consumption, the dose, and the route of consumption. Usually friends and family can provide very valuable information regarding the events that have occurred before or after the event. Obtain history related to allergies, habits, and previous health conditions are usually due in the sample history. Coming to the examination, specifically look for general appearance like dressing, to see the mental status of the patient, any signs of injury, self-inflicted or otherwise, mental and nutritional status of the patient, to find out whether the patient could have been poisoned accidentally without any intention. Odor on the body and breath gives very valuable information regarding the type of poison and whether patient had vomited or not. Tracking marks about the mouth when the patient ingests, it's a poison, they know They cannot just gulp it like water. Usually, some of poison will overflow when they pour into the mouth. And temperature is also a very crucial part of your examination. Specifically, check for GCS, level of consciousness, using either a GCS scale or AVPU scale, pupillary size and reactivity of the pupils, eye movements, cerebral signs and gait when examining the central nervous system. Next, you need to look at cardiovascular system, especially the heart rate and the blood pressure. The respiratory system, you need to count the respiratory rate, axillary muscle usage, oxygen saturation, branchoria and crepitations. GAT and GU, whether there is any urinary retention, oral cavity burns and hypersalivation. Peripheral nervous system manifestations might include tremors, fasciculations, reflexes and tone. Dermal or peripheral signs might include bruising, cyanosis, flushing, injection marks, bullae and scars. Next we come to toxidromes. What is a toxidrome? Substances belonging to a particular chemical or a pharmacological group usually cause a constellation of symptoms which are constant whenever the poison is consumed. This constellation of signs and symptoms caused by a particular pharmacological group is called a toxidrome. Signs and symptoms will enable us to identify a particular group of drugs, and you can plan antidotes and your management accordingly. Identifying toxidrome enables appropriate therapy to be instituted. Common examples for these toxidromes include anticholinergic, cholinergic, extrapyramidal, hallucinogenic, ethanolic, opioid, serotonin, sedative hypnotics. I am going to deal with these toxidromes in another separate lecture completely in detail. For now, you should know there is something called as toxidrome, which when you identify a toxidrome, it makes your life easy to treat the patient. Next comes the diagnostic testing. Measurement of serum drug levels, especially useful in acetaminophen toxicity, carbamazepine toxicity and dioxin toxicity. You don't have to measure the serum drug levels in all the poisonings. Without measuring drug levels, you can manage. These are some of the drugs where measuring the drug level will help you in planning your management. In any poisoning patient, ECG is a must, especially to look for arrhythmias and cardiac conduction abnormalities. Urine toxicological screening can be done, which uses enzyme-linked immunosorbent assay. CBC, RFT, LFT, and serum electrolytes include the baseline investigations, and you need to follow them up at regular intervals. Serum CPK and LDH in case of illicit drug abuse can be done, wherein they can be elevated. Resuscitation is the most important part of general management of a poison patient. It takes priority over your history taking, identifying a poison or anything. Sustaining life is most important until you can institute a specific therapy. So stabilization of airway, breathing and circulation represent the initial priorities. A compromised airway patency or a reduced respiratory drive may lead to inadequate ventilation. Provision of mechanical airway and assisted ventilation is vital in these circumstances. Coming to one by one, airway, note possible upper airway injuries, especially in acid or alkali injuries. Prepare to intubate early before any actual airway damage has occurred. Breathing, note for wheezing, labored breathing and tachypnea. Start patient on 100% oxygen and mechanically ventilate whenever is needed. Circulation, note for tachycardia and possible hypertension. Bradycardia can also occur. Obtain arterial access early, preferably a 2 large bore IV cannulas have to be accessed. Order arterial blood gas and an electrocardiogram, and support circulation with IV fluids and if needed vasopressor or inotrope drugs. So IV crystalloids as boluses of 10 to 20 ml per kg is the first line of treatment for hypertension. Avoid administration of excessive fluids and overloading the system. Persisting hypotension, despite an adequate volume infusion, may respond to a specific antidote. Otherwise, if there is no specific antidote available, you can go for cautious administration of an inotropic agent when it is indicated. The choice of inotrope depends on the toxicokinetic properties of the poison. For each type of poison, you need to give a different type of inotrope, which we will discuss in the further lectures. Treat hypoglycemia with IV dextrose. Patients with Wernicke's encephalopathy may also require thiamine along with dextrose. Next is the antidotes. We all know an antidote is a substance which antagonizes the symptoms and signs of a specific drug, either by competitive inhibition or by non-competitive inhibition. Most common antidotes I'm going to list out here. Calcium channel blocker toxicity, 10% calcium chloride. Hypermagnesemia, 10% calcium gluconate can be used. For cyanide, there is a cyanide antidote kit, amyl nitrate, sodium thiosulfate. We will deal about these antidotes, doses, and how to infuse in detail when we are talking about specific poisons in further lectures. Insulin are oral hypoglycemic agents, dextrose as continuous infusion to maintain a blood glucose level between 120 to 180 milligram per cent. Digoxin or other cardioactive steroids like oleander, you can use FAB antibody fragments. Benzodiazepines specific antidote is flumazenil. Calcium channel blockers and beta blockers, glucagon can be used. Cyanide and nitroprusside, hydroxycobalamin is the specific antidote. For local anesthetics and other lipophilic cardiotoxins, IV lipid emulsion 20% can be used. Methemoglobinemia due to oxidizing agents, nitrates, benzocaine, methylene blue can be used. Opiates, naloxone, isoniazid, pyridoxine. Sodium channel blockers, sodium bicarbonate could be used. For Wernicke's syndrome, thiamine is the antidote. Every emergency department should have a minimum stock of these antidotes depending on the frequency of poisonings in your area. Next, most important thing that you need to deal with the resuscitation is development of seizures. Usually, IV benzodiazepines are the drug of choices to control seizures. Anti-epileptics are normally not indicated and they are not useful. Specifically, if the seizures are INH induced, both benzodiazepines and pyridoxine will be enough, and anti-epileptics will be ineffective. Pyridoxine is going to be the treatment of choice. When you're dealing with seizures, you need to rule out any electrolyte abnormalities or glucose abnormalities like hyperglycemia, hyponatremia, and metabolic acidosis. Second line agents are barbiturates and propofol, and they should be used only after patient has been intubated and has a mechanical ventilation. Agitation can be treated with benzodiazepines. Antipsychotics can be cautiously used as second line drugs. The problem with antipsychotics is they can cause extrapyramidal side effects when they are used inappropriately. Continuing the resuscitation, hyperthermia or hypothermia have to be dealt with. Hyperthermia with temperatures greater than 39 degrees centigrade. You need to go for aggressive cooling, sedation, paralysis, and intubation should be instituted. Toxidromes associated with hyperthermia should be treated with specific agents. Sympathomimetics, benzodiazepines are the specific agents. For serotonin-induced hyperthermia, cyproheptadine. For neuroleptic malignant syndrome induced by antipsychotics, bromocriptine is the drug of choice. Hypothermia, you need to resort to active rewarming, either by using warmed IV fluids or by peritoneal lavage or bladder wash with warmed fluids. Metabolic acidosis, soda bicarbonate is contraindicated in metabolic acidosis induced by poisons. IV fluids and proper oxygenation are the only available choice when you are dealing with metabolic acidosis due to poisons. Ocular decontamination can be done by irrigating copiously with at least 15 to 20 minutes with normal saline or water. Do not use acid or alkaline solutions. Gastrointestinal decontamination can be achieved by emesis, but there is no role in the EDs. Emesis can be cautiously induced in the peripheries where facilities are not available. Orogastric lavage gradually declining. Single dose activated charcoal, whole bowl irrigation, or forced alkaline diuresis can be used. Coming to the orogastric lavage, it attempts to remove any ingested toxin from the stomach. There is no published data that support performing this procedure, and there are numerous complications like injury to the esophagus, gastrointestinal tract, the stomach, and chances of inducing vomiting, and by vomiting there can be aspiration and chemical pneumonitis. So avoid that. Gastric lavage is indicated if there is a recent indication. Consider if the patient presents within 1 hour of ingestion of a life-threatening amount of a toxin for which there is no effective treatment once the drug is absorbed. For all other drugs where there is an effective treatment available, even if the compound has been absorbed, don't institute orogastric lavage. Contraindications for orogastric lavage specifically include corrosive or hydrocarbon ingestion, supportive care, antidote likely lead to recovery, an unprotected airway, unstable, requiring further registration like hypotension and seizures. Complications of orogastric lavage include aspiration pneumonia, hypoxia, water intoxication, hypothermia, laryngospasm, mechanical injury to the GI tract, and it's time consuming, resulting in delay in instituting other definitive care. Next option available is single dose activated charcoal. Toxins within the GI lumen are adsorbed onto the activated charcoal and they are excreted in feces, limiting the absorption of the compound. Activated charcoal does not effectively adsorb metals, corrosives, and alcohols. The indications for activated charcoal include ingestion within the previous hour of toxic substances known to be adsorbed by activated charcoal, where the benefits of administration are judged to outweigh the risks. The dose of activated charcoal is 50 grams orally for adults and it is 1 gram per kg orally in children. It can be instituted as a slurry mixed with water by Riles tube. Contraindications include a non-toxic ingestion, toxin not absorbed by activated charcoal, recovery will occur without administration of activated charcoal, unprotected airway, corrosive ingestion, possibility of upper GI perforation. Complications include vomiting, aspiration of the activated charcoal, impaired absorption of orally administered antidotes. Next is whole bowl irrigation. Polyethylene glycol is an osmotically balanced electrolyte solution. It is administered in large quantities, mechanically forces substances through the GI tract, limiting toxin absorption. Minimize the risk of pulmonary aspiration during whole bowl irrigation by patient positioning. The dose of polyethylene glycol is 2 liters per hour in adults. In children, it is 25 ml per kg per hour, maximum of 2 liters per hour. Indications for whole bowl irrigation: iron ingestion greater than 60 milligrams per kg with opacities and abdominal radiograph, life-threatening ingestion of diltiazem or verapamil, body packers or stuffers, slow release potassium ingestion, lead ingestion including pain plugs containing the lead, symptomatic arsenic trioxide ingestion, life-threatening ingestions of lithium are the indications for whole bowl irrigation. Contraindications for whole bowl irrigation include unprotected airway, GI perforation, obstruction of ileus, hemorrhage, intractable vomiting, and cardiovascular instability. Complications include nausea, vomiting, pulmonary aspiration. The procedure is also time consuming and possibly it can delay institution of other definitive care. Along with performing whole bowl irrigation, you need to start an antiemetic such as prokinetic agent, metoclopramide, which may be required to control polyethylene glycol induced gastric distension and vomiting. The end point of whole bowl irrigation treatment is clear rectal effluent and imaging demonstrating absence of foreign bodies. The next is enhanced elimination techniques. You can use either multi-dose activated charcoal or forced alkaline diuresis to achieve enhanced elimination. Multi-dose activated charcoal, the initial dose of 50 grams, what you give for a single dose activated charcoal, a repeat dose of 25 grams every 2 hours can be given. Indications include carbamazepine coma, which reduces duration of coma, phenobarbital coma, this reduces the duration of coma, dapsone toxicity with significant methemoglobinemia, quinine overdose, theophylline overdose, hemolysis, and hemoperfusion are unavailable at the indications for MDAC. Contraindications include unprotected airway, bowel obstruction, and caution in ingestions resulting in reduced GI motility. Complications of multi-dose activated charcoal, vomiting, aspiration, constipation, formation of charcoal bezoar, bowel obstruction, and perforation. Forced urinary alkalinization or forced alkaline diuresis. Indications include moderate to severe salicylate toxicity not meeting the criteria for hemodialysis. Phenobarbital, chlorphenoxy herbicides, 2,4-dichlorophenoxy acetic acid and mecoprop requires high urine flow rate of 600 ml per hour to be effective. Chlorpropamide, supportive care and IV dextrose normally sufficient. Contraindications, pre-existing fluid overload, renal impairment, uncorrected hypokalemia. Complications include hypokalemia, volume overload, alkalemia, and hypocalcemia, which is usually mild. Next technique is extracorporeal removal, includes hemodialysis and hemoperfusion. Hemodialysis, movement of a solute down a concentration gradient across a semi-permeable membrane. Toxin requirements, it should be of low volume of distribution. There should not be any protein binding, low endogenous clearance, and it should be of low molecular weight. Indications for extracorporeal removal in hemodialysis include life-threatening poisoning by lithium, phenobarbital, salicylates, valproic acid, methanol, ethylene glycol, metformin-induced lactic acidosis, potassium salts, and theophylline. Contraindications, hemodynamic instability, and infants generally it's contraindicated due to poor vascular access and significant coagulopathy. The next technique is hemoperfusion. Toxin requirements include low volume of distribution, low endogenous clearance, and bound by activated charcoal. Hemoperfusion is nothing but movement of toxin from blood, plasma, and plasma proteins onto a bed of activated charcoal, just like in hemoperfusion. Indications include life-threatening poisonings caused by theophylline, carbamazepine, and paraquat. Contraindications, hemodynamic instability. Infants generally contraindicated due to poor vascular access and it can cause significant coagulopathy. Toxin not bound to activated charcoal is also a contraindication. Continuous renal replacement therapies work on the principle of movement of toxin and solute across the semi-permeable membrane in response to a hydrostatic gradient, can be combined with dialysis. Indications include life-threatening injections of toxins when hemodialysis and hemoperfusion is indicated but is unavailable, or hemodynamic instability precludes their utilization. Contraindications, hemodialysis or hemoperfusion is available, poor vascular access, and significant coagulopathy. Complications of extracorporeal removal techniques, fluid or metabolic disruption is limited by hypotension, not for continuous renal replacement therapy. Removal of antidotes, infection and bleeding at catheter site, limited availability, intracranial hemorrhage secondary to anticoagulation. To come to the end, resuscitated the patient who identified the poison. Now is the time to prevent further exposures. Patients presenting with drug overdose in the context of self-harm should undergo a psychiatric evaluation prior to discharge and they should be started on appropriate psychiatric medications. Adults with unintentional exposures or accidental exposures should be instructed regarding safe use of medications and chemicals according to the labeling instructions. And patients should be advised to avoid circumstances that result in chemical exposure or poisoning. In households where children live or visit, alcoholic beverages, medications, and household products, the inedible plants and vitamins should be kept out of reach. Depressed or psychotic patients should undergo psychiatric assessment, disposition, and follow-up. They should be given prescriptions for a limited supply of drugs with a limited number of refills. The fundamentals of poisoning management. Supportive care includes airway protection, oxygenation or ventilation, treatment of arrhythmias, hemodynamic support, treatment of seizures, correction of temperature abnormalities, correction of metabolic derangements, and prevention of secondary complications. Prevention of further poison absorption by gastrointestinal decontamination, which includes gastric lavage, single dose activated charcoal, whole bowel irrigation, dilution, endoscopic or surgical removal of tablets, decontamination of other sites like eye decontamination, skin decontamination, and body cavity evacuation. Enhancement of poison elimination by multi-dose activated charcoal, diuresis, forced alkaline diuresis, activation of urinary pH, chelation agents, extracorporeal removal by hemodialysis, hemoperfusion, hemofiltration, plasmapheresis, exchange transfusion, hyperbaric oxygenation, administration of antidotes where antidotes are available, neutralization by antidotes, neutralization by chemical binding, metabolic antagonism or physiological or pharmacological antagonism, prevention of re-exposures by adult education, child-proofing the homes, and notification of regulatory agencies and psychiatric referral of patients includes the fundamentals of managing a poison victim. Thank you. Don't forget to share and subscribe the videos. Thank you once again.